Our study provides a network meta-analysis of treatment available in giant cell arteritis, allowing indirect comparison for treatment that have not been compared face-to-face, essentially methotrexate and tocilizumab. It appears to place tocilizumab at the top to be superior to methotrexate, but with low to very low certainty of evidence. My name is Dr. Sabine Mainbourg. I am an internal medicine doctor at the Hospice Civil de Lyon in France and currently a postdoctoral fellow at CHU Saint-Justine in Montreal, Canada. I'm pleased to tell you about our study entitled Indirect Comparison of Glucocorticoid-Sparing Agent for Remission Maintenance in Giant Cell Arteritis, a network meta-analysis, which will be published in Mayo Clinic Proceedings. We conduct a network meta-analysis. We combine direct and indirect comparisons for the same outcome, allowing the estimation of the relative efficacy among all treatments available in giant cell arteritis. To do that, we realized a systematic literature review until November 2021 in Medline and Embase. To be included, studies must be phase 2 or 3 randomized controlled trials with parallel design, and enrollment of patients with diagnosis of giant cell arteritis, newly diagnosed or relapsing, randomized to receive a glucocorticoid-sparing agent versus glucocorticoids alone. We extracted data about efficacy and safety. We assessed the risk of bias of trial using the Revis-Cochrane risk of bias tool for randomized trial, the RAB2, and we also assessed the certainty of evidence using the GRAD process, the grading of recommendation, assessment, development, and evaluation. We screened 96 records and we selected 8 trials for extraction, including 5,071 patients. Trials compared glucocorticoids to tocilizumab in 2 trials, oral methotrexate in 3 trials, infliximab in 1 trial, etanercept in 1 trial, and adalimumab in 1 trial. The certainty of evidence with the GRAD process was low to very low according to comparisons. We analyzed the risk of relapse. It was significantly lower with tocilizumab compared to methotrexate, with a relative risk estimated at 0.41, prolonged glucocorticoid and short glucocorticoid. It was not significantly different with methotrexate compared to short glucocorticoid and to prolonged glucocorticoid, neither with prolonged glucocorticoid compared to short glucocorticoid. The risk of serious adverse events and serious infection were not statistically different. 2 drugs, methotrexate and tocilizumab, have been demonstrated to be effective on maintaining remission and are therefore recommended and prescribed in clinical practice. But the absence of head-to-head trials for these treatments creates uncertainty for decision makers. Our study allows to reduce this uncertainty. These findings offer to clinicians the first hierarchy of methotrexate and tocilizumab and place tocilizumab at the top. Another application of the results of this meta-analysis, combined with our meta-analysis of prevalence of relapse on glucocorticoid, is the calculation of the expected relapse rates on methotrexate and tocilizumab that are estimated at 30% and 70% respectively. These results should be used to calculate the number of patients to be included in future trials in giant cell arteritis. GCA is a large vessel vasculitis affecting people over 50 years of age. The recommended treatment at GCA diagnosis remain high-dose glucocorticoid therapy followed by progressive tapering until glucocorticoid withdrawal. However, the long-term use of glucocorticoids leads to numerous side effects. The therapeutic challenge is to limit them while maintaining remission. Our study clarifies the respective role of methotrexate and tocilizumab to provide patients with the best management with the lowest glucocorticoid dose. The results of our study will be complemented by the results of the randomized trial currently being conducted in France, comparing methotrexate and tocilizumab. In addition, we will continue our work on the giant cell arteritis knowledge model with the objective of creating a virtual patient population. Thank you for your attention.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.